Good evening, and welcome to Clinical Trials and Black Folks, the program where we invite leaders from healthcare and industry to talk about the mechanisms that can help us achieve health equity through participation in clinical trials. You see, Black Americans represent about 13% of the population, but only about 3 to 5% of clinical trials. What does that mean? That means is that as new medications and treatments are being developed, they may not be as effective on us. If we want better outcomes, then we have to get involved. In fact, that's the tagline of this program. Involvement improves outcomes. Tonight, I have the honor of welcoming not one, but two guests. My first guest is Nicole Mitchell, Chief Diversity and Inclusion Officer at Cedars-Sinai Hospital in Los Angeles. Yes, at Cedars-Sinai. In fact, Nicole is the inaugural Chief Diversity and Inclusion Officer. In her role, she is responsible for providing strategic leadership and developing and driving the implementation of programs and initiatives that promote a culture of diversity, inclusion, and belonging. My next guest is Dr. Christina Harris, Vice President and Chief Health Equity Officer at Cedars-Sinai. In her role, Dr. Harris guides Cedars-Sinai's ongoing efforts to promote health equity, address health disparities, and foster wellness across the organization and the communities they serve. Good evening and welcome to the program.
Hello. Thanks for having us, Alice. Thanks.
Okay, so my first question. My mom used to tell me when I was growing up that there could not be more than one chief in the tribe, all right? And yet, here we are with two chiefs from Cedars-Sinai. So could you help us understand the difference between the Chief Diversity and Inclusion Officer and the Chief Health Equity Officer roles?
Sure. I like that you started with that. Luckily, we get along really, really well, too. So we like to share. So my role as a Chief Diversity and Inclusion Officer, the easiest way is I think about the workforce, so the people, and the workplace, the culture. So when I am really focused on the workforce, I'm thinking, do our voices represented, our different backgrounds, experiences represented, and the people who are serving our patients, from our physicians to our nurses to our frontline staff to our environmental service workers who are really cleaning up the organization across the board. And from a culture standpoint or workplace standpoint, we're thinking about, are we ensuring our folks have a sense of belonging? Do they feel like they're seeing themselves within Cedars-Sinai? Because that's going to really achieve happiness. And we know that mental health and well-being is such a huge piece, really, of belonging and diversity and inclusion, and kind of health equity, too, with the work that Dr. Harris does. But that's really what we're thinking about, because we know if our folks are happy and we have representation, we're going to have better outcomes for our patients. And that's kind of where we work with Dr. Harris.
Right.
Yeah. So health equity, I think I like to start with defining what health equity is, because that is probably one of the most frequent questions I get. And it's actually pretty simple. It's thinking about allowing every single patient, no matter where they come from, who they are, their background demographic, the opportunity to achieve optimal health, and that they are not limited by some social determined circumstances, by some sort of differential care that they're getting within the office that they or their medical center. So I think about outcomes from the patient experience standpoint. What is their experience when they come in the door? What are the outcomes once they are leaving the door? So who are we serving? Also thinking about who are we not serving? What is the overall health of the community? And how can we as a medical center help to impact all of the patients that we are not caring for, right? Because we only care for the people who come through our door. But there's, often these medical centers, we're big organizations that wield a lot of power in our local communities. We also give back a lot of money often to community. Like, how do we use those resources to ensure that everybody is lifting, not just the people that we care for from a day to day?
Yeah, and I want to just add to that too. I think the other piece is our employees are also consumers of healthcare. So, we also think about, are we taking care of our own people? And are there equity gaps within that piece of our patient population? But it's our own as well. And I think that's a place where Dr. Harris and I really think a lot about our people and communities, because they're in the community. And if we're not taking care of our own folks too, no matter what your background is, how are we doing with the community at large as well?
Sure.
So how does that, so Dr. Harris, how does that impact the community? How does your role impact the community, particularly underrepresented communities like that we try to serve here at Black Doctor?
Absolutely. So again, as Chief Health Equity Officer, I'm thinking about the experiences of the patients who are coming through our doors, often from the community, that come from communities that have been historically marginalized or underrepresented in some sort of way. We know that, in this society of uneven playing fields, not everybody has equal access and opportunities to all of the things. And so what can we as a healthcare institution do in order to ensure that we are giving people what they need to achieve? And everybody needs something different. I'm a primary care doctor. Like, we do patient-centered care. Every patient is different, and that is part of our teaching. And in some respects, health equity is the exact same thing. It's just every patient is different. What do you need based on your social situation, based on your level of income, based on your level of education, all of the things. And so, Chief Health Equity Officers or having people within institutions that think about difference in outcomes is not really new. I will say over the last few years, though, it has picked up steam, thank goodness. I think we have known about differences in outcomes for a very, very long time, 30, 40 years, disparities everywhere, unfortunately. Right. And I think we're at a special point in time where we're starting to think about how do we close some of these gaps, and turning the mirror on ourselves as institutions and thinking about, like, are we contributing to these disparities and making them worse? And I will say, if we are not actively trying to close gaps, then history will tell us that we are making them worse, right? Mm-hmm. So
I mean, you're speaking my language right now, Doc. So Nicole, now we hear diversity and inclusion, and that is typically seen as an internal role, right? So we say, okay, we're going to diversify our workforce. We want to make it inclusive for no matter what sexual orientation, ethnicity, gender, all of those different things. How does your role, though, affect patients in the community when it's kind of viewed as more of an internal type position?
Yeah, I think that's a little bit of a misconception out there, and a lack of understanding the impact of these roles. And I think Dr. Harris makes a great point. We're seeing chief diversity and inclusion officers or chief health equity officers coming up more and more because it's a strategic imperative. It's important for communities to have these voices and for organizations to find ways to understand. So in my role, we find ways to, we can't retain and recruit folks, right? Like, that's kind of the bottom line. We know that people are burning out in healthcare. We know that turnover is high in all these roles. From my perspective, we have to recruit folks, but we also have to meet people where they are in the community for them to even know that we're a good place to work. So again, my place is the people and the culture, but if we're not talking about what that means externally, if we're not listed on, surveys to say that we have met requirements of best places to work, or the Human Rights Campaign Healthcare Equality Index, or blackdoctor.org list. If we're not in those things, then people don't know about the good work that's happening here, and that really does impact the folks that want to come here. I also think being able to highlight our own people, so situations like this, opportunities to highlight Dr. Harris and I, that we work here and we're working really hard to make sure that we're creating equitable and inclusive.
Say it one more time. Say it one more time.
Really hard. So we're working hard to do that and highlighting our own folks to tell those stories, particularly in the Black community. I think that that's important. So knowing who we can highlight in certain communities is part of what my role is too, because we want patients to come here and feel comfortable and know that they're going to be served by people who look like them, who understand their backgrounds, who can speak some of the same language, figuratively and literally. And I think that that's a key piece of my role from an external standpoint, is how do we uplift voices and let folks know this is the place to come for good care, and we have people who look like you and can be there to meet you along on your health journey.
I will say, just to kind of echo what Nicole was saying, her work in ensuring that our workforce is as diverse as it can be is like pivotal foundation to ensuring equitable care. When you think about how do you create a program that is providing equitable care for everybody who comes through the door, you have to have people who reflect the community, right? You just do. It's just the way I mean, study after study after study shows it makes a difference. And honestly, it also makes a difference like in the one-on-one care, but having a diverse workforce changes the way that everybody, even non-people of color, see the patients of color that they interact with. So I need a diverse workforce. Like I'm only going to go so far if I don't have that diverse workforce. Right. And also thinking about the community piece of it, we don't have all of the answers within our institution. The community has the answers. Every solution that we will build will be based on feedback from the community, right? Because, so often as healthcare providers, we think we have the answers, and some of the best tried and true interventions that are sustainable over time really do have the community voice. So that is our job, to bring the community in as well, to ensure that we are doing right by our patients, but as well lifting the boat of everyone in the community.
Well, and it's a fine line, right? You're walking a fine line because you go through all this education and to have the answers, but then now there's this kind of really great concept going on called shared decision making, right? And so when we're broadening that out, we're talking about we're sharing that decision with the community, and so that impact, getting that input from the community, and not just hearing it, but really listening and implementing some of those things from the community can make that environment much more open. Friendly.
It's listening. It's not just listening, right? Because every doctor will say, I listen to my patient. But it's listening to really hear and to really understand and to listen without judgment, right? It doesn't, and that's is real. And I will say it's provided. It is harder to do than you would think. But everybody has their own experiences and their own histories with interacting with the healthcare environment that really does impact how they hear the message that I deliver in the office. And I have to respect that. So.
Well, and I think, that listening piece is critical. And from our perspective, we talk a lot about bias, and we now have it as mandatory education for every single employee at Cedars-Sinai. In addition to our physicians who have privileges at Cedars, they have to do unconscious bias education to even have to walk on campus. And the reason we did that, and there's a lot of arguments out there, does it work, does it not work? We've seen conversations change here and things flag that we may not have seen, and voices internally and our patients' voices being empowered and listened to, I think, more because we've started to have these conversations in a different way. And we talk about hard things. It's not just the basic, like everybody's biased and you all have bias. It's like, here's how it shows up in healthcare. Here's what you need to think about. Here's what can happen when you're stressed that can give you triggers where your bias is going to show up. And I think that's important, to Dr. Harris's point of really listening and really giving your patients the time at all levels of our organization, whether you're a nurse on the front lines and whether you're a patient. I think your patient, as a patient, you should have the expectation that your caregiver, your provider, your physician is really listening to what you're saying and respecting your journey as well. That's so important.
It's funny, like you said, like that word is bias, particularly can be triggering, right? If for certain groups of people, you hear that word, and they already feel, you're about to shame me, especially when you have this education about conscious and unconscious bias. Okay. Oh, they're going to make me feel bad about, things that I've always done. Right. And so help people understand how that is not how we think about it. It's really about, the way I frame it, and you can tell me if I'm wrong, is because you got the chief title. So I think about it as creating an environment where everybody can be their best selves, right? And where I'm not stepping on your toes because I'm not aware of you or aware of anything, and I'm really kind of conscious of what I say and do that can make you feel uncomfortable or not welcomed.
Yeah, and I think we frame it up to we all have them. Like I can go into a meeting, and I do think it can be triggering to certain communities. And I think there's an approach to it, right? For everybody to come along on a journey. I'm a firm believer of everybody's on a different place on the inclusion journey, and you have to meet people where they are to move them along. And, in our roles, we have to be comfortable knowing that I might be all the way at the end of the inclusion journey, but I'm working with folks who are at the beginning, and I have to approach bias differently. I think you hit the nail on the head though, Ellis. It's saying like we all have it. But it's really being able to talk about it, start to be aware of how it can show up in our interactions with each other as colleagues, in our interactions with our patients, in our interactions with community members. And if we aren't talking about that at Cedars, we do believe that that's foundational to health equity work and to diversity and inclusion work. And we made this strategic decision that because it's foundational, we got to talk about it. Otherwise, we're not going to be able to take steps in our journey with this work too. But it is a delicate topic. But I think what's rooted in it is, Dr. Harris said it earlier, we all have our own perspectives, our stories, things that we bring to the table that impact our interactions with each other. All three of us do. We all grew up differently. We all live in different places, and I think that all plays a role in how you see the world. And that comes into the workplace. And if we aren't talking about it, then it's going to impact our patient interactions and our colleague interactions too.
That's right.
So Dr. Harris, I did a little bit of research on you. So Harvard educated, but then you go and work in a federally funded housing project in New York City for over a decade. Mm-hmm. And so reading that and learning about your background, it always seemed like equity was part of who you are. And you go to UCLA and you create a position there for health equity. So talk about why is health equity so important to you that I know it has to be important to you when you're working in the project, but when you go to a situation like UCLA, why is it important to bring that to you wherever you go?
I mean, I will say as a physician of color, an interest in equity is not so unique. I will say for me and for many of us, but not for everybody, but for many of us, it's the reason we went into medicine, right? We went into medicine to improve situations that we were either in as kids, seeing in family members, all of the things. It's about purpose, it's about passion, and it's about doing your part. And that there's in any field, you can give back and you can do your thing. But for those of us who have an inkling to go into healthcare, for me, doing it with an equity lens or with historically marginalized communities was really what woke me up in the morning and gave me purpose and passion. It is, always what I've done. I ended up working at the VA, which was fantastic as well. A wonderful place to provide care and, with real support services as well. And I will say more and more, and, thinking about the medical school classes that we are graduating, I'm hearing more and more voices who want to go into medicine in underserved communities. Right. And this is not just people of color, right? Because this is not just my job as a Black person or a Black doctor. This has to be everybody's job, right? And so as educators, we do as much as we can to nurture that within our learners and not beat it out of them. So when they finish their training, they actually do go in and serve the communities that really brought them to medicine to begin with. It's really a gift. It's a privilege to have been part of this process.
So if you're just joining us, we are talking to Dr. Christina Harris and Ms. Nicole Mitchell from Cedars-Sinai. We've got two chiefs. We got the Chief Diversity and Inclusion Officer and the Chief Health Equity Officer at Cedars-Sinai Hospital in Los Angeles. So the name of this show is Clinical Trials of Black Folks. I do have to ask you one question about clinical trials. So there is.
I'll let the physician answer this one.
But no, seriously, and I talked about in my opening about how there is a lack, underrepresentation of people of color in clinical trials. We understand that there is a big push from the FDA to have more involvement in clinical trials. Why do you think that's important? So we'll start with Dr. Harris. Why do you think involvement for people of color, Black, brown, and whatever, to be involved in clinical trials?
Yeah. I mean, you alluded to this, Alice, when you started. All of the advances that have gotten us to where we are in healthcare have come through some sort of study or clinical trial. We need them. It is how we have extended our life expectancy. It's how we've extended, how well people do on certain treatments. And without that diversity and within the clinical trial population, we are really limiting our ability to have good science and to have good clinical care, right? And yes, black versus white, 99% the same DNA, but there are differences that matter. We have different communities. Sometimes we have different diets. We have different, exposure to pollution and housing and all the different things. This makes a difference how medications work in our body. And so I think the more homogeneous or same that study populations are, the less we will be able to generalize treatments to everybody. We are not all the same. Our lives are not all the same. And that changes how medications impact on our body. And so that is really why representation is so important in cancer, in studies in general, cancer studies, pharmacology studies, cardiovascular studies, all the studies.
But I want to add to it on the flip side of, I also think having diversity in the staff and the researchers in those clinical trials is just as important. And finding folks as you're going to figure out what your career is, knowing that we do have these gaps of representation in clinical trials, but we have the gaps in representation of the folks doing them and being part of them from a medicine standpoint, from a healthcare standpoint. And I think that we have to change that perception as well, not only the participants in the trials, because Dr. Harris is right, Ellis, you're right. Like, we need the voice there, we need the research there, because we aren't all the same. But we also need, on the other side, folks that look like us doing those trials to ask the questions, or to even be at the table to ask the question of, like, why don't we have any Black folks in here?
Yeah. Changing the narrative. Yeah. Different questions get asked, and as well, like, listen, if you have cancer and you were showing, if you're trying to find a clinical trial, this is a scary time for you, right? Showing up and being able to see someone who looks like you. I'm 45 and I just experienced having my first Black provider. Let me tell you, it made a difference. I've always been on the other side of it, where people have been like, oh, Dr. Harris, I'm so glad, my Black female patients. But I, at 45, experienced it for the first time, and I was like, oh,
that's what it feels like.
Whatever she says, I'm gonna do it, right? And so it was powerful. And so can you imagine, at such a vulnerable time where you were so sick that you need something different, like, that makes a difference. And it doesn't have to be my doctor. Maybe it's the person that's asking me the questions. Like, it makes a difference.
Oh, I feel you. I had a doctor's appointment today, and my provider was Black, and we just started, after I got done with the exam, we just started talking, right? And the nurse comes in, she's like, "Everything okay?" We're like, "Oh no, no."
You gotta make sure they're not gonna charge you for that extra time.
in here talking, and it was like, wow, this was like, and there was so much connectivity, right? We could relate to so many different things, and I told her what I did and whatever. Oh my gosh! And so we started having all these great conversations, and it was like, wow, there is a difference, right? And then there's been studies done on that. There's Black patients' outcome improves appreciably when they have a Black provider. So we know that's the reality of it. The sad part of that is there's not, there's a dearth of Black providers, and so what we have to do, and what Nicole is doing in her role, is making sure that if it's not the provider, that the staff, whether it's the nurses, whether it's the orderly, whether it's somebody that's touching that, anybody has patient contact, there's a diversity of people that have that. So you have that voice in the room that says, hey, why are we doing this study at the university when the people that are living around the university, the people that can benefit from this study, them, to get diversity, we're going to have to do some different things, like maybe provide some bus passes or some lunch or something to get people to and from this clinical trial.
Yep.
Before, I don't know if we're about to leave clinical trials, but if we are, I'm going to say this. So I think that there is a long-standing misconception that the reason these statistics are the way they are, like people 12%, clinical trials like 3 to 5% or something like that, is because it's all about mistrust. Oh, no. People do Tuskegee. Oh, I'm not going to ask her if she wants to be in that trial because she's not going to want to do it. I know Black people don't do trials. In fact, when studies have shown that when you offer get to the point where you are offering somebody a clinical trial, whether you are Asian, Black, Hispanic, same rates of saying yes. The problem is not everybody gets asked to the dance. Right? Not everybody is in the position to have the provider who knows about the clinical trials or has access to a medical center that's in the community, showing up at the churches and doing the things and building the trust and says, oh, hey, we've got this trial for you. Right? So same likelihood of saying yes to the trial, which to me is like, it's an incredible statistic because that is not what is commonly thought of. It is often thought of as just mistrust. And what I don't like about that is that it puts it back on the patient. And honestly, the Black community, they probably shouldn't mistrust us. For 350 years, we have had segregated care and unequal playing fields. Like, have we earned the trust? No, we have not yet. We are trying hard. But, there's reasons behind that. So I just want to throw that out.
Absolutely. No, that's fantastic. So Nicole, Dr. Harris bringing a good point. So how can the community help, right? So we're talking about the provider side. We're talking about what we could be doing better with these trials in order to make them more inviting and making them more open and having a different train of thought to kind of eliminate some of the things that the barriers to participation, right? And that barrier could be something as simple as, okay, yeah, we've got childcare on site here. So you can bring your child with you, leave her while you're, participating in a trial, and we'll get you home. I heard about a trial that partnered with Uber, and they give you a credit with Uber, and they get you to and from in a car ride. So that you don't have to ride public transportation. They can get you there back a lot quicker. So innovative things like that. So how can the community help more in your work in terms of diversity and inclusion?
I think not being afraid to use your voice. I do believe that we probably do have mistrust issues, but I feel as if we're having a shift in the healthcare industry right now where, from an equity standpoint, particularly, if you speak up and you use your voice as a Black person, as a consumer of healthcare, say what's missing, right? Say that I don't see myself represented here and ask why that is. And that makes my job easier, to be honest. I mean, easier to an extent. I'll say that piece where, like, if you say, hey, why don't we have a Black anesthesiologist when I come walk in? Luckily, we have a couple over here at Cedars. But that helps me say, hey, we're hearing the patient's voice. We need to make some change. We need to make some intentional efforts to ensure that we have representation in this area, in this specialty. In trials, I think asking if you have that relationship with your physician or your care provider, like, what do you know that's going on? I heard something on blackdoctor.org from these two crazy ladies at Cedars-Sinai who were talking about the importance of representation. That clinical trials, we need to be represented more. Do you know anything about it? So use your voice, and your voice can be utilized in so many different ways. And Christina and I were talking, Dr. Harris and I were talking about this earlier. Sorry, Christina, I was trying to stick with the Dr. Harris the whole time. But we were talking about this earlier, where something as simple as we have a beautiful art collection at Cedars-Sinai. This is a place of healing, right? We had a Black patient walk through and say, I'm here, I love this organization, but I don't see myself represented in any of the art here. And this is supposed to be a place of healing for me too. We have a beautiful art exhibit now through our partners and community members of all Black art by Black artists. And we've changed the conversation of what does representation look like in our art. That's just one small example of a patient speaking up. Also speaking up of, like, we're primary care providers for Cedars-Sinai that look like me. Okay, thank you for saying that. Let's start to do some intentional efforts of changing things. So the community and our patients, speak up. Use your voice, because it matters. And if we don't have that diverse representation around us, your diverse voice helps make that difference.
That's right.
It's a funny story. We did a lung cancer show with some of your colleagues, and one of the things I said when we had the patient on there, or the survivor on there, and I said, when she was detailing the story about all the different providers that were part of her care in treating her lung cancer. And I said, as a Black person, we don't like to have a lot of people in our business, right? So to have, just keeping it real, but that's cultural, right? I don't need all the people in my business. And she was named with like 13 different people. And so what I'm saying is like to providers. So Dr. Harris, I can see in your work is telling providers that this is a cultural kind of phenomenon. We just don't like people that, so you're going to have to deal with that and address that in your treatment, right? You can't just run into, okay, we got to do this, and that. Wait. And somebody else is coming. We're like, well, that's too many. It could be overwhelming. And so if we can have our providers recognize that and be conditioned to, okay, I have a Black patient in front of me, I might need to deal with this a little bit better before I start throwing a whole bunch of people at her.
And I think even just to broaden that out, like everybody, yes, there are some tendencies in our community, and that is true, Atlas. But everybody is different, right? And we cannot do the same thing for everyone and expect the same outcomes.
Right.
So that is touching base with I'm about to ask in 10 people into this room. Are you okay with that? Oh, you're not? Okay. So let me figure this out.
Right.
And it's sometimes we just get into the habit of this is what we do.
Right.
And that's not very patient-centered of us. And that's, that is really why we're here.
Absolutely. Well, there was a great comment in the comments, and we're talking about kind of the difference in just they're having a hard time finding a Black provider to help them get a prosthesis, right? And because there's difference in body types and things like that. And so really understanding that the diversity is needed, and we're just thankful that Cedars is doing it. Last question, so we can get you out of here. I know I almost promised you 30 minutes. We're a little bit over, but it's okay. So any call to action or messaging that you would like to leave the audience with on the importance of health equity and D&I?
You want to go first?
No, go ahead, Nicole.
I should have said a name.
Yeah, don't let us. We'll talk over each other and we'll come up with it. No, I think back to my last comment is be confident in your voice and know that you don't have to settle for what you're seeing in your healthcare relationships. And we were joking a little bit earlier, like if you aren't comfortable with your provider on your first date, you can ask for another one. You can go try somebody else, right? Break up with them. But I think it's use your voice in all aspects of your healthcare journey. And also, it's almost demand your health provider, your community hospital, that they think of things differently and meet people where they are. To me, that's the biggest piece. Our patients and their families for us are at the center of everything that we do. And if our patients and families aren't comfortable using their voices to help make a difference and change, then we're not doing something right. But it's a two-way street. So I really think use your voice, speak up, because that helps us do our role. So we want y'all to support us too, because we're 2 Black women in leadership roles, and we need y'all as well.
And I think my final comment will just kind of follow the lines of Nicole as well. It is, speak up because people are listening. What many probably don't know is that, at Health Equity, there are accreditation bodies, payers, everyone's coming out with policies. Like, there is an expectation that hospital systems have to do better. It's like written in the rules. There are rules. People start losing money if they don't do it, right? So people are listening. So use your voices from that standpoint. And the other trend, which is like long time coming, is this idea of focusing on all of the different aspects of that impact care, such as we call it just social determinants, like the social drivers of health, being able to have access to housing and food and a secure environment where there's not issues with safety and social cohesion. We are changing the narrative and finally bringing in these very, very important factors into the conversation. Health systems are going to start asking you about your social determinants of health or social drivers of health. Payers are going to have to start to cover some of these things, transportation, all of these things. Right. So ask, right? Just start asking, because the conversation is changing. They might not be there yet, but these things make a difference in outcomes. And so that is part of providing complete care.
Absolutely. Well, I want to thank you too for giving us this time to come and talk about your roles and how it's impacting not only what you do every day, but how it's impacting the community and changing the community. Oh, you're welcome, Yolanda. So Yolanda asked Dr. Harris for some resources about how Black patients do better with Black doctors. So I found a couple of articles and put that.
Oh, there's some good ones out there.
So go to Dr. Google, and sometimes Google is good for some things, but yeah. So Yolanda, I would say just Google Black patients, Black providers, and outcomes, and there is a slew of research and articles all about that. And so it is really well supported. You're welcome for the program, John. But again, I want to thank our partners at Cedars-Sinai for really partnering with us and let us have these two wonderful guests here. See yourself, right? And so I think that's what Nicole is talking about in terms of diversity and inclusion. That's what Dr. Harris is talking about in terms of equity. See yourself in the process, whether if you're a patient, see yourself in that process. It does better if you see yourself, but if you don't see yourself, inject yourself. Make yourself present in that process. When we're talking about clinical trials, that same mantra happens. Make yourself present in that process so you can speak to it and speak well about it in the community. If it's not going well, then you report that too, so we know what's going on. Again, the tagline of this program is involvement improves outcomes. If we're not involved, we cannot complain about the outcomes that we're getting. So that's what we have this time. We will see you in 2023. We do this on the first Thursday of each month. So we're going to see you again in 2023. Thank you too. Again, this was a fantastic conversation, and we'll see you all next time.
Thank you.
Thank you, Alice, for having us.